Hello and welcome. This is Donna Cryer. I am the host of GLI Live and the CEO and founder of the Global Liver Institute. I am so excited today to bring you this episode through the lens of kidney health advocacy in action. As certainly many of you hopefully have grown to appreciate during this series that we have on the interconnectedness and the interdependentness of liver health and kidney health, the connectedness of liver health advocacy and kidney health advocacy has been so important over time. And we are happy to shine the spotlight on that today with our guest, Troy Zimmerman, who is Director of Special Projects for the National Kidney Foundation. Hello, Troy.
Hello, pleasure to be here. Thank you, Donna.
Thank you. You know, last night I was listening to a Kenny Rogers, Dolly Parton song that had the title, "You Can't Make Old Friends." It was only something that's, developed over time. And so I am very honored to be able to call you a very dear friend of longstanding. We'll put it that way.
Longstanding sounds better than old. Thank you.
Yes, exactly. And so I remember your first day at NKF, working in government affairs, as I was doing likewise for United Network for Organ Sharing. And, we have been partners in advocacy ever since, having achieved a lot, I think, that I'd love to discuss today on behalf of liver and kidney patients, transplant recipients in particular, and their access to innovative medications and increasing the quality and standards of care. So, Troy, why don't you tell us about what it means to be a special projects director at this point, and just give us an overview of the work of the National Kidney Foundation.
Sure, I'd be happy to. So let me start with I'll start with myself. I joined the National Kidney Foundation's Government Relations Office almost 24 years ago, and we established the office at that time. And I was very, very fortunate to be hired by somebody who came from our headquarters in New York and who had been with us already, oh goodness, over 2 decades. So many of you probably know Dolph Cinciano, and he still does some consulting work for us. So I was really fortunate to work under him, learn under him. Donna mentioned, we met early on in my career, and Dolph educated me not only on the issues, but on the players in the field and so forth. And so I was hired as the Congressional Relations Director, and most of my career has focused on combination of congressional relations, but also working with coalitions and like-minded organizations. About a year ago, I transitioned into my new position as Special Projects Director, which really allows me to take a deeper dive and I guess you could say work on fewer issues, but more in depth and things that are more of a long-term nature. I still assist with the congressional relations on our key priorities with our new congressional relations director. So we do have a lot of collaboration in that regard. I appreciate the opportunity to still have my foot there. Having said that, it's very difficult, as Donna can attest to doing congressional relations in this virtual environment, and I certainly miss that interaction. Just built so many great relationships on Capitol Hill over the years. I still some people there I've known for 15 or 20 years, but increasingly you're meeting newer and newer staff, and I just always enjoy that. I enjoy, working with people who are new to that environment. As far as the National Kidney Foundation, we have multitude of programs for patients and professionals. This week, in fact, we're hosting our annual spring clinicals meeting, which started yesterday and runs through the week. A lot of professional programs, not only for the dialysis population, but also we have a rather extensive transplant professionals population, and even pharmacologists as well. But we have surgeons and transplant physicians. We have dialysis social workers, but also transplant social workers. And then our membership also includes advanced practitioners, dietitians, nurses, technicians, et cetera. So we really represent the whole spectrum of the kidney disease professional community.
I think that's fantastic. And I would hope that both of our former bosses, mine, Bill Lawrence, who, trained us and brought us up together, would be proud of how we are um, mentoring the next generation of government affairs and policy directors in health advocacy, and passing along their great work and work ethic, and insistence on getting your research and your data, as well as developing those relationships and thinking long term, and all of the wonderful things that our respective bosses taught us and that we're passing along well.
I would agree. I think too, the patients, regardless of what organ you're waiting for, all the patients have that connection. I mean, the kidney patients understand the needs of the person waiting for the heart or waiting for the liver, and vice versa. So it is, certainly it's a great opportunity to be able to combine efforts on things that are, UNOS related or organ donation related, et cetera. So I always appreciate that opportunity to work with the broader community.
Absolutely. One issue that both our communities have been working on, to some effect lately, has been that of living donor. Sort of leveling the playing field for those who want to donate, so they're not paying for the privilege of donating. And there have been several high profile, and we know so many thousands of more who are not high profile, people who feel that they have to resort to social media to be able to find a living donor. And it's heartbreaking and ultimately inequitable for people to have to for your ability to get a living donor to rely on the strength of your social media skills and savvy and network. And so how NKF helping to lead the community to make it easier and more accessible to increase the number of living donor transplants that we can do.
Well, we've done a number of things over the years, and I've been privileged to work on a lot of those. Certainly, living donation is considered the best opportunity to significantly increase the number of transplants. Deceased donation, as you know, Donna, is pretty stable, from year to year. And furthermore, living donation is the preferable the type of transplant for kidney recipients, a much better long-term graft survival. Short-term is not much different from deceased donation. But we've done a lot of things in policy to help remove barriers to donation and living donation. A lot of them are financial barriers. And one example is many years ago, in the last reauthorization of the National Organ Transplant Act, I was able to work on something for NKF where we helped create a program to offset unreimbursed expenses related to donation, and that's primarily travel and subsistence. But we felt that individuals of lower economic means, were being prohibited or to donating, especially if they had to take unpaid leave from work. So we worked with both leaders in the House and the Senate in both parties on the reauthorization of the bill to create a program which ended up being the National Living Donor Assistance Center. And for those of you who are familiar with that, that that's helped thousands of people since it was implemented to with their out-of-pocket expenses. And again, obviously the recipient's insurance pays for the donor's expenses, whether it's private coverage, Medicaid, Medicare, but the out-of-pocket expenses can be, quite significant. I remember we had one advocate that I was working closely with from Florida, and he kept, detailed records of how much it cost him to donate to his brother because he had to travel from Miami to New York on multiple occasions. And he said it was a little bit over $5,000. He said, clearly, I had the money, and I would have, I did it. But a lot of people might not have been able to do that, and that would be, very frustrating for a family member. Other things we've worked on, I think you were probably involved in that, Donna, was the legislation to clarify that paired kidney donations did not violate NOTA. I think that's a wonderful opportunity. I mean, if you have a family member or a friend who wants to donate and you're medically incompatible, you still have that opportunity to match up with two or more other people that to start either a paired donation or a kidney chain. It's hard to believe that that was not permitted. Well, there was uncertainty as to whether it violated NOTA. I think at the time when we were working on that legislation, there were 3 to 5 programs nationally that were doing it. Of course, that's also something that we thought would pass in about 12 months, and I think it took 3 years to get it through. And it was a simple bill. Nobody really objected to it, but for one reason or another, there were roadblocks. But that certainly has paved the way for the pair donations. I know there's over 1,000 done every year now, and I think there's a lot more opportunities for that. And let me just say one last thing that we're currently working on is, for several years now, we've been working to try to enact legislation called the Living Donor Protection Act in Congress, which would prohibit discrimination against living donors in obtaining or the benefit levels or premium levels for life insurance, long-term care insurance, and disability insurance. That legislation was reintroduced in February in both houses. Already has 21 or 22 co-sponsors in the Senate, has about half that many in the House of Representatives. So we're hoping to get that through. But in the meantime, we've been working at the state level. About almost 20 states have enacted a similar law in the last several years. Most of them passed the bill in 2019 or 2020. But it's up to about 17 or 18 now, and it's pending in some other legislatures still. And NCAF has worked with the transplant community on those bills as well. In some instances, we've even had our volunteers or our local staff testify before the legislative committee. So we're pleased with that, but obviously we'd like to get a federal bill.
I think that's so important, and it's been very exciting for us that many of the GLI Advanced Advocacy Academy alums have been working in those states on that legislation. Some of them are both, liver and kidney patients,
Mm-hmm.
and testify to the importance of both. And we've seen successes in many states, and so it's exciting to be able to partner on that state level as well as on the federal level, on these important issues.
And
Also,
as you said, the social influence and the social media opportunity is very important. I mean, I remember, I don't know, probably 10 or 12 years ago when there's controversy surrounding billboards. Who can afford to, put up a local billboard? I need a donor. And that was, before there was widestream social media opportunities. But that's something that we do as well. We have something called our Circles of Influence program, which encourages people how to use social media, community groups, etc. But the NKF also has a program called The Big Ask, The Big Give.
mhm.
And that's a series of, used to be in person, now it's primarily virtual webinars on how to teach people to, become comfortable making that ask, the big ask, and, going to their family members, community members, colleagues, et cetera, and asking for that, if they would consider donating a kidney. And then also, the big give is making the potential donor comfortable and answering any questions they might have and doubts and concerns about donation. So we've had a number, countless workshops nationwide. We do locally, sponsoring sometimes with transplant centers, and those have been very, very successful. Additionally, we have NKF Peers, which our Peers program puts a transplant patient in touch with another transplant patient for support. And then we also have a program where we can match a potential living donor with somebody who's donated, so that the person who's either in need of the organ or wants to donate an organ can talk to somebody who's been through the process already and make them more comfortable.
I think that's so important, and that peer-to-peer support and understanding, really, what is it like? How did you feel? How did you overcome that, concern or issue, is really essential. And we'll make sure that that information is in the show notes.
Great, thank you.
Some of our interns have already made use of that and have shared that with others. And, I do hope that so many more people, are able to experience the miracle that I was blessed to receive, and are, as healthy and as, productive as I've been able to be over the past 26 years. So it is something that is really core to our being able to facilitate.
Well, certainly for a lot of individuals, the process can be overwhelming and the ask can be overwhelming. So it's great to have.
We have a question about, do you have to be transplanted in the state where the Living Donor Protections Act has been passed for your donor to qualify? So someone's listed in Ohio, for example, but they were successful in getting the law passed in Kentucky.
No, that would not be a requirement, because the protection is for the, would depend on this. Obviously, the donor would have to live in the state that's enacted it, but that would be the only requirement.
Great, thank you. So for those of us who've been involved long enough to see the sort of arc of legislation, and how long sometimes these things do take to pass, we've jointly had quite a bit of success and momentum over the past 2 years for things that you and I have started and worked on even 20 years ago, and that's very satisfying to
Yes.
to see. But I think for patients becoming patient advocates, and for new government affairs staff, to realize, even with a lot of buy-in about things being the right thing to do, and even I think in our cases so much bipartisan support of what we want to achieve. Sometimes it does take a long time to actually bring things all the way across the line. What do you think sort of allowed us to break through and build the momentum to a point where we're actually able to create the understanding and the will, and then the votes, or the passage for legislation such as the increase in immunosuppressive coverage, or things like organ procurement organization accountability. We've seen so many breakthroughs in the past 2 years. How did those occur, and how can we make sure it continues?
Well, I think the immunosuppressive legislation always had strong bipartisan support. When you explain to a member of Congress that Medicare pays for the dialysis and pays for a transplant, but doesn't pay for the anti-rejection meds, they were flabbergasted. And I say that, the members who serve on the health committees know the ESRD, Medicare ESRD program inside and out, but it's understandable that, a rank and file member of Congress probably doesn't know that, the nuances of that. And a lot of times we'd meet with offices, and if it was with the actual member, and they'd hear that and they'd say, this is crazy, I'll sponsor this bill. So the holdup on the immunosuppressants was always because there was a net cost. And as you know, Donna, anything, has to do with a Medicare benefit, if you're going to expand it or create a new one, you have to have an offset. What really made two things, I think, that paved the way last year was, first, the Trump administration was supportive of it. And in fact, they issued 2 cost estimates in the spring of 2019 that showed cost savings. But more importantly, because it's Congress, the Congressional Budget Office also determined it would be a net saver over a 10-year period. So the fact that they didn't need a pay for, there was just no reason not to do it. And I mean, if it had not passed, we would have been dumbfounded. In fact, about halfway through last year, we were doing something publicly, an event with one of the sponsor staffs, and I remember the staff member said, "It's not a question if this bill will pass this year; it's a matter of when." So we fully expected, I'd say by midsummer, because we were working closely with one of the congressional committees to try to include it in legislation in the summer. We were giving them data that they had requested about disparities and inequities and graft survival, et cetera, and obviously, how many transplants are lost due to lack of immunosuppressive coverage, and it was clear that they wanted to get it done. So that was a cost issue. Now, some of the things you raised, transplants, there's other issues involved, and I think it's a lot of it depends on how an issue or how a proposal is going to affect a local community or the local OPO or the local transplant centers, et cetera. But by and large, there's very strong support on both sides of the aisle in Congress for transplant issues. And they understand, they recognize obviously that that improved life, well, in the case of non-kidneys, it saves the patient's life, but in a case of kidney patients, it's a much preferred course of kidney replacement therapy.
Absolutely. When I started, I remember we had members of Congress who were transplant recipients, like Joe Moakley, and so I think part of what contributed to the success of the past few years, having members of the administration who had transplant experience and
right.
understood truly both the anxiety and the
Correct.
human costs of waiting on the list, of potentially not having access, and then how restoring a family member back is not just a transfer for the individual, but for the family and to be able to have those. There's so many things we don't know how to cure, or we don't know how to do, or we haven't cracked the code yet, or we don't have all the pieces, like we did earlier when we had transplant surgery, but not the right immunosuppressants. And so to have something that does have all the pieces, that does have, healthcare systems, physicians and medications all teed up and ready, and then not have people access, to it. I think resonated in a way, when you added the humanity to them.
Yeah, I mean, it obviously will take a lot to really make a significant improvement in the wait list and in the gap between the number of people registered and the number of people getting transplants. But it is frustrating that the so-called simple things that could be done, even those take time. I mean, immunosuppressive was a perfect example. We know there were people losing their transplants without having the coverage, and I'm sure there were a lot of people. We know for certain there were a lot of people who weren't even listing for a transplant because they didn't think they could afford the drugs, and they certainly wouldn't ask an individual to be a living donor if they thought they couldn't properly care for the kidney down the road. So that's just one example of something that could have been done a long time ago, and obviously took a long time, as you know. But there's certainly a lot of issues involved in it. But I think removing the common barriers, even the things like pair donation. I mean, there you got somebody who wants to be a donor and it's not compatible. That is just, I hate to use the term no-brainer, but it was a no-brainer.
Right. Another issue that has moved successfully with the advocacy of the kidney health community was getting vaccination to people on dialysis. Like, again, another no-brainer. You have people who are connected to care, and they're getting dialysis on 3. They're defined as high risk for COVID infections and complications, and also they're disproportionately people of color. And so, sorry, I'm about to sneeze. Spring. There we go. So why was it, I know, why was it so hard? It's hard questions to answer, but, the path to getting dialysis patients, prioritized for vaccination. Just sort of walk us through some of the context of those conversations. A lot of this episode, I'm thinking for liver health advocates to really learn from our friends and colleagues like yourself in the kidney health, so that we can understand how to best support our patients, even though we don't have all of the structures and the ability to provide the exact type of data and cost impact in liver health, because we don't have an ESRD program or
Right.
but on the COVID vaccination prioritization that passed in the rescue plan, tell us just sort of how that advocacy happened.
Well, let me preface that by saying I was not closely involved in the conversations that the Kidney Foundation had with the administration and with the dialysis providers, et cetera. But I am familiar with them. Certainly, as you mentioned, COVID-19 has had a tremendous impact, disproportionate impact on dialysis patients. In fact, at one point last year, patients with end-stage kidney failure had the highest rate of hospitalization due to COVID among all Medicare beneficiaries. And that that's not only dialysis patients. That could include transplant recipients as well. But definitely, it's been disproportionately impacted. You mentioned, communities of color. They've been, disproportionately impacted as well. Certainly, whether they're a transplant recipient or dialysis patient, they're at much higher risk of COVID, because of their comorbidities. And of course, in the case of a transplant recipient, their immunosuppressive status. But dialysis centers, they're a natural, practical site to provide the vaccine. And that's something I don't think that's undeniable. And they already provide vaccines for flu and hepatitis, pneumonia, et cetera. So, not only is a dialysis center, it's a natural extension of a service that they can provide. And of course, patients, a lot of dialysis patients would find it very, very difficult to get to a community setting to receive their vaccine. Not only do they, 3 of the 7 days a week are out of the question because of dialysis, but a lot of dialysis patients also have transportation issues, et cetera. So I think without being able to do it in center, they would have to wait much, much longer. Certainly, they're at higher risk in center because of the environment they're in, the congregate environment that they're in with dialysis. So I do know that we worked for months with the dialysis providers to try to make this a reality. It was something that they wanted to do, last fall when it was clear that the vaccine would be available shortly thereafter. And it was, I think everybody expected to be available by the end of last year or very latest, very beginning of this year. So it is something that we collaborated with them. We reached out to HHS. We worked with the companies to be able to provide that. And hopefully it'll be a game changer. I'm sure it'll take a little bit of time to get it fully ramped up, but it'll make a significant difference, because otherwise, as I said, I think the patients would have had to wait in just an incredibly long period of time, and a lot of them might not have ever gotten the vaccine out of difficulties of scheduling it.
Absolutely. We've already heard so much relief expressed and hope expressed by our patients who are on dialysis, as well as maybe having to do with liver issues. And you're absolutely right. Their inability to get vaccination elsewhere, but it was really problematic. And as the eligibility now grows to include every adult, I always think of sort of the pool of Bethesda, who kept waiting for her chance to dip her toe in the pool when the angel stirred to restore health. All of these other people sort of passed for them every time, and them just languishing. And so, we certainly did not want that to happen to our.
Yeah, and patients, they were anxious. Our patients for the last year have been anxious to get the vaccine, whether it's dialysis patient or a transplant recipient. A lot of our transplant recipients, who, prior to COVID were, leaving home in the workforce, et cetera, they just hunkered down, understandably. They would. I can think of a few people who, would even have their groceries delivered to doorstep, and that was that. They step outside and get what was there, and that would be it. And or they'd go out for medical appointments. Of course, one thing that happened with COVID was a large increase in telehealth appointments, and that's something that patients took advantage of as well. So I think anything that can be done, with vaccines and other opportunities to help, get our patients back into the daily mainstream, so to speak, they're very anxious to take advantage of.
Absolutely, absolutely. So, African Americans are 4 times more likely to have kidney failures. Hispanics, almost 1.5 times more likely to have kidney failure. As a liver transplant, it's rather shocking. The doctors would just sort of accept that, oh, you may need a kidney transplant someday, instead of saying, there's a developing chronic disease, and we're going to monitor these things, do these things. I had to be very, active in, educating my physicians and in advocating for the supports to lay the assumption that it's inevitable. We'll know when that's prevalent, and so we want to make sure that we include the NKF resources, that you have in the show notes to help patients of color.
Yes, that would be very helpful. On some of our programs, 35 to 40% of the participants have identified as being Black or African American. We have a lot of programs in Spanish as well. Actually, last year we did a live webinar in Spanish to alert and inform Hispanics on the dangers of COVID-19. So that was something that was very well received. And we did some other public policy things last year as well. For example, we partnered with NAACP on a congressional hearing to talk about the impact of COVID and the disparities in the minority communities. And going back to the immunosuppressive issue, one of the things we were asked to provide data on to the Senate Finance Committee when they were looking at the legislation in the middle of the year, they were clearly supportive of it, but trying to build a case on the committee among a broader group of senators. They had asked for data on minority access to transplantation, but also they wanted data on the graft survival of transplants for minorities as well. So absolutely, I mean, as you said, African Americans are 4 times more likely to have kidney failure, and Hispanics are about 1.5 times, 1.3, I believe it is, to have kidney failure. And a lot of questions remain on, do different ethnicities and racial groups progress differently? Even once they are identified with CKD. So there are a lot of questions that remain to be answered, but certainly inequities in access, and that's something that's very important to the NKF to address.
We appreciate that. One of the things that has impressed me about NKF over these course of years, among so many, is that you really literally set the standards in terms of what quality care looks like. And as someone who convenes, as you mentioned before, so many stakeholders across the community, consensus on various issues. Maybe talk for a moment about how you set the quality standards so that everybody can move towards that.
Well, we have our professional guidelines, the KDOQI guidelines, which are not just nationally recognized but internationally recognized, and they're peer reviewed, and they are updated on a regular basis, I guess you could say, every several years. I mean, it's probably 8 to 10 years, I guess, on average when they're updated. But those guidelines have really are recognized, by Medicare and by payers as a standard to follow. And again, they can be broader general and broader issues are going to be a very specific area of research. And I think that's certainly that's helped move the needle a lot. Having said that, there's still a lot that we don't know about chronic kidney disease, and as I said earlier, the progression. We're woefully lacking in clinical trials. A lot of data comes from observational studies rather than the extensive in-person studies that one would like. And if there are clinical trials available, it doesn't mean that every patient has same access to that. They might live in areas that are too far away from the centers, or be a lower socioeconomic background where it's more difficult to participate. And that's something that we are really trying to work with the NIH and others to expand those the opportunities for more clinical trials. Because until we, have a better understanding of the differences in disease progression, we won't be able to obviously, treat it to the extent that we want to slow the progression. And it's an uphill battle because 9 out of 10 adults who are estimated to have chronic kidney disease in the U.S. are unaware of it.
Right.
So just, first step is to, increase awareness and increase testing. We actually have something that we started last year with Department of Health and Human Services and the American Society of Nephrology, which is RU to 33%. And that refers to the estimated in individuals who have chronic kidney disease. And we have a 1-minute test you can take to determine if you're at higher risk of chronic kidney disease. Because again, the general public's awareness of it is just is not, it's inadequate. But and there's high risk people as well. I mean, it is so frustrating to hear patients say, I didn't know this. I mean, you're always going to have patients have an urgent start dialysis for one reason or another. And sometimes that's because, kidney disease is asymptomatic, and patients a lot of times will say, well, I thought I was working too much, or, I was, I wasn't getting enough rest. I was putting in a lot of hours, etc. But what's really frustrating is sometimes they have the medical data and the necessary steps aren't being taken as aggressively to treat it. Sometimes it's like, for example, with patients with diabetes, the clinician's more focused on the diabetes than the potential kidney damage. So half the battle is knowing the risk factors, and especially if you're a high risk patient like a diabetic or somebody with hypertension or family disease, but then also, once getting the patient and the practitioners and clinicians to work together to do everything they can do to manage the chronic kidney disease.
I think that is an excellent note to end on. The tools for awareness, particularly, I think we absolutely share the same situation with people having their lab data, but needing to know how to read it, the implications of it, how to make sure if their physicians aren't, paying, attention with some urgency about all of these factors, whether the liver enzymes are elevated or their creatinine is high, for example. We see this as an opportunity, I feel, through our joint work and education that both of our organizations do to ensure that people are getting the whole person care, and that sort of the siloed thinking perhaps of the past of your liver's okay and the rest doesn't matter, or your kidney's okay and the rest doesn't matter. We really, I think, need to have a conversation, and I think both of our organizations are driving the conversation to make sure that people are aware of how to have heart health, brain health, kidney health, liver health.
Yes.
All in the same person, and they all need a more holistic attention. And I look forward to
that's an excellent point, Donna, because for so many kidney patients and liver patients as well, I'm sure they have comorbidities.
Right.
And that it's not one thing, it's probably not two things. It could be 3 or 4 different comorbidities. And as you mentioned, Joe Moakley, I remember he used to say, the nephrologist needs to know a little bit about everything in the body, because he recognized that the kidney impacts a lot of different functions. So very good point.
So there are things that we continue to work on and pass on to others to solve as maybe we someday retire and
Well, maybe we can have this conversation in a few years and talk about all the things we did between April 2021 and whatever date that is.
that's fantastic. I look
Um,
at
just keep, I would encourage everybody listening to just keep making the noise and, getting to your policymakers, whether it's a elected official or, the agency and the people at the state and federal level, and educate and make noise.
absolutely, absolutely. I look forward. I look forward to that. I'll try to get over my shyness and reserve.
I don't think you have to worry about that.
To let's get loud, as my
Yeah.
friend likes to say. So thank you,
You're very welcome.
Troy. Thank you to everybody watching and listening. And until next time, and you can find all of this information for this and past episodes on the globalliver.org website, our Facebook, Instagram, and Twitter. And we'll make sure to put the National Kidney Foundation information that we mentioned in this episode in the show notes. So come find us. And thank you. Stay well and stay connected. Until next time.
Thank you. I enjoyed the opportunity.